Well, good evening, everybody. Thank you for taking your time out of your busy schedules to join us tonight. You can see I'm still in the office. I've got my scrubs on. I've got my jacket. I haven't even changed yet after a day of patients. But I really appreciate that people take the time. I'm sure a lot of you either just finished with patients or you maybe ran home and grabbed a bite to eat and you're with your families. What I appreciate about all the docs that I meet that use these devices is I find they're just all into dentistry, right? That means they're really doing as much as they can. They're learning as much as they can to be the absolute best practitioner, to offer the best level of care. And I love surrounding myself with those type of clinicians, right? They're not just show up to work type of dentists, pediatric dentists. They really want to do the best work possible. They want to involve technology and training to really give the best care possible to their patients. So I do appreciate all of you joining tonight. I do appreciate all the hard work that our NuSmile team does for us. They are actually available a little too much. Sometimes I have to tell them to stop being on their phones late at night. They should be with their families. So you are all very appreciated. So tonight, the topic is Mastering Advanced Intraosseous Delivery of Local Anesthesia in Pediatric Dentistry. And this is a two-part webinar that we give every single month. And in a little bit, what we're going to do is we'll do a poll and find out what your level of knowledge and experiences with intraosseous anesthesia. But this is the mastering series, okay? So we're not going to dive way into the basics. We're going to cover some of that tonight, but really what we want to get down to is how do you become an expert in these devices? What are all the things that are in the instruction manual and not in the instruction manual in order to make sure that you feel comfortable using these devices? I will tell you that since I integrated both a sleeper one and a SOA into my practice, I have not used a traditional syringe for any patient under 14 years of age. Haven't once, right? It's actually strange to me now to pick up a standard syringe. I couldn't even imagine giving a block to a 5-year-old. I really couldn't. And I did that for 20 years. It would be odd to me. And these devices have completely changed the way I deliver care. So I do appreciate everybody being here tonight, and let's get down to details. So just as I mentioned, this is a two-part webinar, okay? So my friend and partner in crime there, Dr. Ann Bynum, teaches the introductory webinar once a month, along with Dr. Megan and Dr. Miranda there. And Dr. Ann we're going to pair up and do some of these, do some swaps, and she will do some of the mastering. But if you are new to these devices, don't own a device, I really want you to tune in. The other thing I want you to do is come back and watch these webinars. Every time we're going to give you new content. So we don't ever have the same content every single time. We update these as we go. When there are questions, when there are concerns, these are live, right? So there's content I have on here that people posted questions 2 days ago. So come on back, watch these. What I did was I actually and I still do this, I turn them on in the car and I just listen on the way to work. And there's things I learn every single time. So, these can be found on NuSmile's website. If you go to nusmile.com and go to the webinars there, you're going to find all these past recordings. So just a little bit about me. I'm a second-generation pediatric dentist. So I had the fortunate ability to take over the practice from my father. So I've been in practice now 21 years. And I like to say that I split my time about 75% patient care and 50% dental education. I find that joke funny. My wife does not, but I really am passionate about teaching. Pediatric dentistry has given me a really wonderful life and career. And if I can give back to my profession, I've done things correctly. So I have a practice in the Bay Area, and along with my practice, I also own a teaching center, and the teaching center really is focused on teaching pediatric dentists. I believe we're the only dedicated teaching center for pediatric dentistry, hands-on, at least in Northern California. And we do courses about every month or every other month. And we'll learn some of the things we talked about tonight and direct composite dentistry. About a year ago, I moved into my new facility. There it is. And when I'm not teaching about restorative dentistry. I'm one of those interesting people that I like bookkeeping and accounting, so I teach courses on that and financial management and dentistry. I really believe in enhanced magnification. We won't talk about that tonight because I could take 2 hours doing that, but I really believe that in order to give appropriate restorative care, the best care possible, you do need magnification. And I like dental photography and I like dentistry overall. This is my contact information. So I will tell you that all of us that teach these devices, we are available to you. So the NuSmile team and all of us that are KOLs for NuSmile and Dental High Tech, there is more help available than you're going to need. I promise you. I'd love to see, even on weekends, on holidays, people post things online and immediately there's 4 or 5 people that jump in and offer help. So if you are one of those people that you started with these devices and you tuned in tonight because you're struggling, great, fine, let's help you. What I encourage you to do is if you really need the help, you can videotape and should have shown me it. You can use your iPhone and take a video if you're struggling. But if you have questions, please reach out to us. Feel free to email me. Mike, you can do a QR code there and scan. But there is help out there, and we would love to help you. So we want everyone to be a master of these devices. Just a couple pictures of my office there. We try to keep everything nice and open and bright. I didn't go with a theme. We just wanted, nice colors and professional and clean. And this is I have a couple larger operatories where we work out of, and I teach courses in those too. And if something you want to do, please come see us. So I want to turn things back over to Chris for a minute, and we want to get a good idea of what everyone's experience are with these devices. So Chris, do you want to help us out?
Yep. So just launched a poll for everybody to participate in. It is anonymous, so just go ahead and fill that out. It's 4 simple questions. Again, like Dr. Solomon mentioned, we're just trying to get a sense of the room and see, who has the devices, who's a little bit more experienced, who's brand new to this journey. And it can help Dr. Solomon kind of tweak his presentation as he goes. So we'll give that a sec for everybody to go ahead and participate. We are almost at 50% participation, which is great. Thank you, everybody. Looks like we have mostly SOAN users. Several don't own the device yet. Large majority is actually using it on all of their patients, Dr. Solomon, with a small percentage kind of falling back, it looks like. Not many have tried using it from the lingual instead of the buccal.
Oh, we're going to talk about that tonight.
I bet we are. And then looks like everybody, for the most part, is using it in drive versus cruise, with a few no answers just because they don't have the devices yet, but looks like mostly in cruise. So got about over 70%, about 70% participation there. So thanks everybody for participating. We'll go ahead and keep moving.
Great. So most of you own these devices. If you don't, that's okay. This will be good information. And remember, this is recorded. So once you get your device, what I would do is after you finish your onboarding, I would go ahead and watch, the intro courses, and you can always come back to one of these to get more information. Okay. So just a little history about myself. I graduated my residency in 2003, and that was early on into all the amazing products that NuSmile makes, and that was just Signature Crown. That was it. And I've been here since then, and I've seen just the amazing growth of the company and the products they offer. I hopped on specific like BioFlex. I hopped on those right away. I think they're phenomenal. The chairside space maintainers are so much easier, especially when you have space loss. And tonight we're going to talk about the SOAN Sleeper One. But I will tell you that stay posted, because NuSmile is always looking to innovate, or is always looking to bring new products to the market specifically for pediatric dentistry. So keep an eye on the website. Come to courses like the Restore. You will learn quite a bit. Just some disclaimers. I am a KOL for NuSmile, NuSmile Tech and Dental High Tech. So I do teach these webinars. I do teach other courses. And the reason why I do this is because I am extremely passionate about delivery of local anesthesia via the intraosseous method. It has completely changed the way that I do so much of my restorative dentistry. And I could talk about this all day, and that's why I'm here tonight. So well, for those of you who are new, right, we had, I think, maybe, 8, 9 of you that are new. Why do we do this? What's the point of giving anesthesia via the intraosseous modality? And number one, I say pain-free, right? I think we have to be careful using that term pain-free, but I will tell you that my experience is 8 out of 10 or 9 out of 10, and some days it's 10 out of 10. I see absolutely no reaction from my patient whatsoever. These days, I think I'm closer to 9 out of 10 to 10 out of 10, meaning that that's not just a cooperative 7-year-old. That is a 3-year-old that needs ENF extracted. They literally do not feel any stage of the injection. And I'll talk about that case on the bottom, but once I saw I could give one intraosseous injection and numb all 4 of those primary teeth and have 0 response from my patient, I was sold, and I knew that I was not going to give local any other method. Okay. So we have to also ask ourselves, are patients feeling pain, or are they feeling pressure? We need to remember, and we'll talk about this in a little bit, is that inside that, once you get past the plate and you're in that cancellous bone, there are not nerve endings there, okay? There are proprioceptive, you feel pressure, there's nociceptors there, but they're not feeling pain. So I want you to make sure that you understand the difference between something hurting your patient versus them maybe reacting to a little bit of pressure, because that can happen. That can happen. Not having to give multiple injections in a site is one of the greatest things ever. You look at those lower anterior teeth, if I can give one easy intraosseous injection right at the midline there between O and P, and that's it. It's faster, it's less stressful for my patient and my parents, and everybody's happy at the end of the day. One of the most important features of intraosseous anesthesia is not having collateral numbness. I had one of my closest friends who worked with me for many years in the past, and she had 2 patients this week, and she is a very advanced practitioner with big swollen lips that they bit. And we've all had those stories where our patient may, afterwards the parent doesn't tell us, but rushes our child down to the emergency room, and they get to the ER. I know this because it's happened to me. And the ER doc says, oh, your child has a massive infection on their lip. They didn't have a massive infection on their lip. They just bit themselves, right? I have not had, to my knowledge, one patient that has had collateral numbness via an intraosseous injection in my practice since I started. We don't have to give bilateral blocks. That's one of the most uncomfortable things, I think, for a patient. But well, I'll tell you what happens to me all the time is before I was able to give intraosseous anesthesia, I would treatment plan one side and have them come back another side. You don't have to do that anymore. We don't have to worry about midlines. This whole idea of giving a block and having to worry about numbing right to the middle, we don't have to worry about that anymore. You can complete treatment on both sides. You're not going to have any collateral numbness of the lip or tongue. And it's definitely fewer appointments. I will tell you that we won't get into this tonight, into the details about finances, but I'll tell you that my units have more than paid for themselves in a very short amount of time. And my cooperation level, not only are my patients not having pain with their injections, but they're not having to come back. We all know that first visit may be a little tough for a patient, and that second visit, and by the time you get to that third visit, even cooperative children have a really tough time. And if I can make my appointments shorter and I can have fewer appointments, everybody wins. Everybody wins. For those of you that are new to intraosseous delivery of local anesthesia, it took me a little bit of time to realize that it really is immediate, profound anesthesia in that area that you are delivering. I didn't believe it at first. It took me a little time. I gave that IO injection. I would wait a little bit just because I needed to feel better. But I'm telling you, if you do things correctly, if you give your injection in the right site, use the right anesthetic, use the right quantity, you can go ahead and, like this picture here on the right-hand side, your pediatric, a standard, what we used to do a block, you can go ahead and give your, half a carb or 2% septicane with epinephrine. and immediately start even with extractions or with pulp therapy on those teeth. All right. You start right away. So appointments are shorter, behavior management is less. If my patient's comfortable at the beginning, they're going to be much less difficult towards the end of the appointment, and I can get more work done and everybody's happy, right? I want to optimize my appointments. I want to keep my appointments short, and I want to be able to see other patients during that time. All right. We all know that a happy parent makes everybody happy, and a stressed out parent is sometimes we have those families where you have two patients in the operatory, if you know what I mean. And I will tell you that I've noticed a marketable difference in just the affect of parents during procedures when they know that I'm giving injection. And I often will look up and I'll make eye contact with a parent and their mouth is kind of open because they just can't believe that their 3-year-old literally didn't feel the injection. That parent in their mind already had, oh, this is going to hurt, even though they told me it didn't. And to see that look on parents' faces are amazing. And I'll talk about this case here in a minute. So this is, if nothing else, if intraosseous delivery of local anesthesia just allowed us to not have collateral numbness, just that alone would be great, right? This is uncomfortable and it looks worse than it really is. And it's really nice to not have to tell parents, well, don't have your child eat for 2 hours after the appointment. I can do a procedure, give my IO, wherever that is, even for extractions, and they can go back to school without having to worry about biting their lip. And we know that kids, miss way too much school, especially for dentistry. And this is a way of getting those kids back to school. All right. We talked a little bit, and I joked with Aaron about the onboarding, and I did that for a reason. I will tell you that my experience is, and I won't call you out because some of you may be on here tonight, is anytime a doctor is struggling, the first thing that I do is I asked if they completed the onboarding. Okay? The onboarding, there was a lot of time and attention that went into the onboarding with Dental High Tech and NuSmile Tech. And some of you have delegated the onboarding to your team members. And I implore you to not do that. Okay? You need to complete the onboarding yourself. You're going to be using these devices every day for the rest of your career, and you need to know how to use it. I want to know what all the little lights are, what all the little beeps are. I want to be a master at this procedure. And the only way I can do that is go through that onboard training. And all of you who have gotten this information when you got your units, so please, please, please do the onboarding, schedule your virtual meeting, you'll get your needles. And then if you have questions, you have concerns, we already know that you've learned that basic amount of material from the very start. These are new. Thank you so much, NuSmile, for putting these together. NuSmile themselves didn't just come up with this. They pulled a lot of us, and we had meetings, and we talked about, what we want parents to know. And, use these devices to also help build your practice, right? Yeah, it's great that our patients don't have pain. It's great that our parents are happy, but we want to get this out in the community that this is available, right? This is available for our patients, and you can purchase these through NuSmile. These are great brochures. I have them up in our operatories. And if, you can just have them mounted there. And if a parent wants, they can take one from the wall. And this has really good basic information about the devices. If you have questions, if you have problems, please, please, please reach out to us, okay? You can take a screen print there, or take a photo if you want these slides, but this is also available online. So you can, if you have questions, if you are having an issue with a procedure issue with the unit, you will get help. They will be more than happy to reach out to you. They'll get back to you right away. I will tell you that sometimes they may be traveling, like to a restore course. So if you have a time where you reached out and you didn't get an answer back like immediately, they may be traveling, but my experience is you're going to get a call back or an email back in 24 hours or less. Okay. They are dedicated to these devices. They know the banal minutia as much as I do, or, Dr. Bynum, they know these devices in and out, and they will help you. Please, 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 if you are not part of the Facebook group, please go ahead and join. What I ask of you is one simple thing. If you are having any issues or something doesn't work out, do me a favor and post in this group. Okay. And the reason being is many times when someone is struggling or they had a negative experience with their sleep or one of their SOAN, I will tell you that 9 out of 10 times it's a user error, and we really want to promote these units. So if someone posts, oh, I had a problem with XYZ, the general public's not going to necessarily know that it was a user error because someone didn't know how to do something. So I would much rather you post questions in this user group once you get a unit. And I believe you can join even if you do not have one yet. Is that correct, Chris? Or
Yes, that's correct.
So go ahead and join right away. And if you have questions or concerns, post pictures, post video. This is a group of docs that are really dedicated to these units. So let's take a step back. I think the important thing for us to understand, especially as a new user, is you may have not realized this, but you have been perfusing local anesthesia through the cortical plate into the apex of your tooth since day one of giving local anesthesia to your patients, right? These devices are just giving you the velvet rope of skipping past that periosteum and that cortical plate. So when we give an infiltration into the soft tissue there, that bolus of local anesthesia has to perfuse through the periosteum, and it's got to perfuse through the Volkmann canals and the version canals in that cortical plate to get into the cancellous bone and then down to the apex of the tooth. And I never really thought about this in detail until I started using these units. That's really not an efficient way of giving local anesthesia. You've got to give a fair amount more of that solution, that bolus of local anesthesia, that local anesthetic to be able to move through the periosteum, to move through the cortical plate, and then get all the way down to the apex of the tooth, right? And what happens along the way? Well, because we're giving that bolus of local anesthetic on the outside of the periosteum, all the other anatomy that is there, the lips, the cheek, the tongue, that's also getting numb. And that's where a collateral local anesthetic or collateral numbness is occurring, is because if you're going to give an infiltration, there's no way to not have numbness of the lip. Now, if we can skip past this and give that injection through the cortical plate into the cancellous bone, we're not going to be worried about numbing all of those other accessory and connected structures. And this is what we see. We're going to give that infiltration, your standard dental infiltration. It's got to take time and volume to fuse the bone to get down to where you need to have this go. So now the difference is we're changing our delivery to a targeted delivery of local anesthetic down to where we want. I don't want it in the lip. I don't want it in the tongue. I don't want it on the face. I want to give that bolus as close to the apex of the tooth as possible. This is where I need to have my local. Now, when I think about giving a block to a patient, it seems so foreign to me. Someone had a great analogy, was that if I need to numb my finger, why would I give a block at my elbow? You can numb your finger that way, right? But you're going to have all this other anatomy numb along the way. You're going to have to give a higher volume. You're going to have to numb these other accessory structures, and it's going to take much more time. If I need to numb my finger, I just want my finger numb. And that's exactly what's happening with these devices. So if you're new, don't get so wrapped up on, oh, this is new, I'm worried. You're doing almost the same thing you always have. You're just delivering your local anesthetic into a different place. And we want to get that local as close to the apex as possible. That's how we're getting immediate onset of delivery. That's how we're able to use less of a volume. That's how we're getting profuse and sound anesthetic 365 degrees circumferentially around that tooth. So we're going to do things differently now. We're going to skip. That's that velvet rope. You need to get into the nightclub. That velvet rope's out of the way. We're going to pass the periosteum. We're going to pass the cortical plate, and we're going to give that bolus of solution as close as we can to the apex of the tooth. And that's really the only main difference with intraosseous anesthesia. So let's look at what this animation and what this looks like in general if you're not familiar. So this is really a 3-stage process. This first step is all we're going to do is just numb. We call this the papillary triangle. We're numbing the gingiva and we're numbing the periosteum into the area and just into the area where we're going to pass our needle through that cortical plate. And what you can see here is we're going to pass through the cortical plate into the cancellous bone. Now, this device looks a little different. It's slightly different than what we have available right now in the United States, but the method is exactly the same. We are giving that anesthetic as close to the apex as possible. I want you to think about this area of the cancellous bone as a vessel, right? Once you pass that cortical plate and you give that local into the cancellous bone, anything that's inside and surrounding and touching that area is profusely and immediately numbed, right? That is a sea change to what we were doing before. So this is a 3-stage technique. I want to just go, I know most of you have these units and you're familiar, but let's just go over basics for a little bit here. So number 1 is we need to numb the soft tissue before we pass the needle, obviously through the soft tissue, through the cortical plate into the cancellous bone. So that very first step is numbing of the gingiva and the papillary triangle, and most importantly, the periosteum. We know that the periosteum is a highly, highly innervated area of anatomy. Then the second phase, which is what people have to get used to at first, the first time we all gave local anesthesia in dental school, you remember to an orange, that first pop through the orange was a little dicey for some people, right? I distinctly remember that day in dental school. Trust me, you do it a few times, you'll get used to it. And it's actually now, it's a comforting fact. You're not always going to feel that pop. We'll talk about that later today. But knowing that you pass through that cortical plate, you can feel it. You know that you're most likely into the correct area. And then we're going to give our anesthetic. Now, giving the anesthetic via manually and an electronic device are 2 very different things. And it's not only the correct, not giving it with a manual device, there's a large difference between electronic delivery of local anesthesia, and we will talk about that. And not only electronic, but a piece of hardware that is designed only for intraosseous delivery of local anesthesia. Some of you may have seen this video before. Thank you, Paul Bond, for this. Absolutely excellent. So let's just show you a video of, for those of you that don't have these units yet, of the 3 steps. So this first step, we can see we have a D on our needle. That D is facing away from the soft tissue. We're coming in at about a 15-degree angle, and we're going to give this local in small drops. This is drop by drop delivery of your local anesthetic. Now, you are superior to the periosteum at this point. If you go in at too steep of an angle, or at the wrong angulation completely, or in the incorrect area, your patient may have pain. And we're going to talk about that because that's definitely something we cover in the mastering. So that first step is just getting the soft tissue and the periosteum numb. And then this is our second step where we have our manual bone penetration and then delivery of the local anesthetic. I promise you, if you try to do this manually with a device, either by hand or a device that's not designed for intraosseous anesthesia, you're going to have pain from your patients. And you're going to have issues with perfusion. Now, I want to make one point with this video is that in order to really be able to, for you guys to see, you notice how he didn't have his hand resting on the teeth. I want you, when you're delivering your local, you're going to position things a little bit differently. I want you to make sure you have a finger rest on these teeth. Okay. One of the main reasons why people bend needles is they don't have the correct position. They don't have the correct finger rest. And we're going to talk about that here in a little bit. So let's get into some of the pearls for tonight. And there was a post a while ago, and this still comes up, is that dentists were worried about using a needle for delivery of intraosseous anesthesia for children. We need to remember that these needles, the ones we're using 99% of the time in our pediatric practices, are 9 millimeters. You can see if you wind up touching and developing tooth bud with one of these, we need to have a little talk about dental anatomy. Okay. Unless, the tooth is ectopic in the wrong position, but you are miles away basically from a developing tooth bud. I am not worried about, having any issues with either the needle touching or pressure with that developing tooth. You are very far away, right? When it comes to angulation, This is something that is important as far as how we hold excuse me, one quick second. There we go. How we hold the needle and the angulation that we approach. If you immediately see blanching, and for those of you who are new, this happens to new users. If you see immediately profuse blanching both on the buccal and the palatal side, you may have just passed through the papilla. What I encourage everyone to do, and this may sound funny for those of you who've been in practice for a while, the next time you extract a primary tooth, look in the socket. And not just look in the socket to see if you have root left or you still have soft tissue, there's infection. Actually take out the tooth, go ahead and rinsing off a sterile saline and look at the cortical plate. Look to see where you would be entering with that needle. Look to see the angulation of bone. I promise you, if you do that in several areas in the posterior and the anterior, you're going to have a much better idea of the angulation that you're going to place these needles. Okay. And if you have questions about any of this, this is where you're going to post. What we did here for this webinar is we're going to, the next several slides or so are going to be from posts or concerns from doctors. And that's what we want to do under this mastering webinar is give you content that was just brought up online. So pretty much all of these questions or concerns or things that we need to clarify have come up in the last 2 months. How do we be effective with giving these injections? Number one, we need to pick the right anesthetic. Now, we know that pretty much every single time we're using Septicane. Now, there are some times when we use 1 to 100,000 epinephrine and 1 to 200,000 epinephrine. In my practice, most of the time I'm using the 1 to 200,000. We keep both. Later on, we're going to talk about how you make that selection. When it comes to quantity, I want everyone to remember that sometimes less is more. If we are giving higher volumes of local anesthetic that are needed, sometimes that's actually not a good thing. But I will tell you that you should be finding you're using far less local anesthetic with an intraosseous technique than you are with a standard block, okay? And when it comes to time, here's an important concept, because we have had some people say, well, this takes me longer to do, to give the whole injection from step 1 to step 3. I promise you that if you really looked at your time from giving a block appropriately, right, not just putting the needle in and pushing as fast as you can, but if you give a block at, let's call it a milliliter a minute, and then you waited for that local anesthesia to take effect, I promise you it's the same amount of time. It just may feel longer to you. Until I started using these devices, what I really did not appreciate was I've been giving local anesthesia too fast. I really have. And that's where patients are feeling pain and pressure. So what are my 4 mantras? The 4 Ps, my mantra before any injection. As soon as I walk in the room, number 1, I'm going to pick up my unit and I'm going to look after I sit down. Is it on, right? Please remember that there are settings here available for time, and the default is to have your standby time at 10 minutes. You're going to get 30 carps out of that. Most people will leave it in that default amount of time. I do, but you can change this, and you can extend your default or your time before this powers off on you, but just know you're not going to get as many injections, okay? So number 1, is it on? The reason why I say that is because it's happened to me before where I go ahead and give my stage 1 or attempt to give my stage 1, and I have the patient position, I have my hands positioned, everything's ready to go. I go to give my stage 1 and my numbing of the papillary triangle, and I realize the unit is off, right? Not a good thing to have to stop and turn it back on. This probably happens more than I would like for people that are new. So number 1, let's make sure we turn the power on. Then number 2, before we approach our patient, we need to review the radiographs. We should not be using these devices. We shouldn't be giving any intraosseous delivery of local anesthetic without looking at a radiograph. We need to look at where our injection site is appropriate. Is there anatomy in the way? What does our bone level look like? Is there infection there? Do we not have organized bone where it's an appropriate site for that delivery of local anesthetic? I want to choose not only my injection site, but which local anesthetic am I giving? Am I using Septicane with 1 to 100,000 or 1 to 200,000? I want to have suction ready. Typically, what I do with my practice is after I give the stage 1, anytime I come off the pedal, my assistant automatically knows to turn the suction on so we don't have any local anesthetic that gets on the tongue. And we're going to go through our normal tell, so, do, and if we need to, we're going to view things with the patient. So number 1, power, and then number 2, it's checking our radiographs, our injection site, and suction, and reviewing with parent. So it's power, our plan. Then number 3 is our pedal. I want to make sure the pedal's in the right position. Now, some people like the pedal on their right foot. Some people like it on their left foot. That's really up to you as far as positioning, but I do want you to make sure you can actually see your pedal. Because especially if you're new using these devices, your staff may have your sew-in, your sleeper one set up ready for you, but that pedal may be around the corner from the chair and you just can't see it. And what I don't want you to have to do is go in initially for your first step and you go to have perfect positioning in your papilla, and then you realize you don't have a pedal, right? So power, plan, pedal, and then lastly is your position. I love Larie's term. She talks about the circle of safety, if you've heard her talk about that before. And what she's talking about is making sure your patient is close enough to you and positioned enough so you're stable, your patient's stable, your pedal's in the right position. If you do all 4 of these things, power, plan, pedal, and position, you're going to have a much better chance of having a pain-free and appropriate delivery of local anesthetic. I included this slide because it happened to me this week in my own practice. So we had someone that wasn't used to setting up these units, and they took the cartridge right out of the sterilizer, right out of the autoclave, and they cranked it down. They put it on their sew-in and they cranked it down, and it was a little bit more than finger tight. And when they went to unscrew the cartridge after the patient left, the ring was actually pretty snug on the cartridge itself. We need to remember that these just need to be finger tight, especially for our needles. And the reason for that is on your sew-in, when we position our patient, we need to make sure that we can not only see the D, but we can also see the lights. So if your team member tightens that needle too hard down and they bury it all the way to the hub and really finger tighten it, you're going to have a hard time rotating that needle. And you will rotate the needle so the D is in the correct orientation so you can also see the lights with your sew-in. Now, you're not going to necessarily need to do that with your sleeper one because the lights are circumferentially located around the unit. So this is just light pressure with your fingers. Don't need to over tighten. This is a big one that came up over the last month. I talked to several doctors that said, you know what, I don't know. Everyone says this is a magic piece of equipment that they don't have any pain giving an injection, but every time I give an injection, I'm having pain. And I will tell you that my theory is it comes from 2 different issues. Number 1, we know that for that initial delivery, we need to only numb the papillary triangle, correct? We don't want to give too much local anesthetic here because if we have blanching all the way down to the vestibule, we may have collateral numbness. That we want to avoid. We need to remember that instead of entering your end of your Effitech needle right at the middle of that papilla, I want to go slightly lateral too. And the reason for that is when you give that first injection, when you are entering that soft tissue, it's easy to get a little heavy-handed and push too far laterally. And the problem is we know that PDL is a highly, highly innervated area. And what I'm assuming is that some people are starting actually to put the needle tip in the midline, and then they're pushing too far into the soft tissue, too far forward. They're advancing too far forward, and they're actually either touching the periosteum or the PDL. So my goal is to maybe be about 1 millimeter away, even maybe 2, but probably closer to 1 millimeter away from the middle of that papillary triangle. All we're looking for is blanching just in about a 4 millimeter area. That's all you need. You don't want to have this where it's all the way down to the vestibule. The other concept, and once Dr. Prin showed me this, it absolutely made sense. These needles are so sharp that you don't need to push like you would with a standard, even a short needle. You want to just think about bending the needle, just slightly pressing down. If you slightly press down instead of actually advancing, I promise you, you're going to easily pass through the soft tissue and you lower your chances of bumping into the periosteum. If you wind up touching the periosteum before that patient has adequate local anesthesia and blanching, I promise you your patient's not going to like it. Okay, so it's angulation and it's position of your needle. If you do both of those things and you're still having issues with pain, please take a video, have your staff just grab a phone, take a video, get permission from the patient. Please send it to us so we can help diagnose what the issues are. All right, the lights. Now this is for SOAN. There are lights. There is a light on the Sleeper One, but we're mostly going to concentrate on SOAN because most of you have those. Is that there are these indicator lights while you're giving the injection. I talked to a doctor a couple weeks ago, and she didn't even. She said, "I'm supposed to look at the lights." Yes, you're supposed to look at the lights. Just remember that when you are delivering that in the third stage of this delivery of local anesthetic, you're going to see, at least in a perfect world, 1 to 2, maybe a third light. And what this is an indication of is any resistance of that fluid passing through the tip of the needle. So if you have a needle that is bent, if you have a piece of cortical bone or soft tissue that's stuck into the tip of the needle, that resistance is going to increase. The wonderful thing about these units is that algorithm will not let you get in trouble. So if it senses that there is too much pressure for too long, it's actually going to shut you down and it's going to retract your needle. So that safety mechanism is built in there. Some people are worried about, well, am I giving too much pressure? The unit will keep you safe. So you want to see that 1 to 2, maybe a third blinking light there on your SOAN. If you see 4, my steps typically are to back that needle out a little bit, maybe slightly rotate it because I could be up against some bone, or I may have a blockage to the end of my needle. I don't wait very long though. If I go to reposition and I find that I'm still getting blinking to 4, I'm going to take my needle off and just put a new needle on. Okay. Don't waste the time. Just put a new needle on. My experience is then the resistance is going to go way down. This was another point that someone made as far as why is this taking me so long to inject? What I found out about from talking to this doctor is they were coming on and off the pedal. And they were a little worried about how much local they were giving, so they would have the pedal down and they would come off and go back on and come off. Every time you come off that pedal, it's going to reset this curve, right? If you're in drive mode, correct? So if you come off that pedal, please remember that this curve's going to start again. So you want to just continuously have that pedal down. Again, excuse me, I said drive, you're in cruise, correct? In cruise, Chris and Jordan and Eric?
Correct.
Correct. So if you're in cruise, you're just going to keep your foot down and it'll continuously deliver your local anesthetic till you come off the pedal. But if you're doing on, off, remember you're starting that curve, and it's going to slow you down. It's going to slow you down. All right. This was posted from our group. One of our wonderful doctors, I got on the phone with him. He said, I don't know what to do here. I posted this permission. He said, well, my cartridge is breaking. Every single one of these are breaking where we screw this into our SOAN. Well, come to find out that they were just cold sterilizing these units, right? It wasn't going into an autoclave. And so number one is we don't know how many times this was used. Remember, we get about 50 uses per cartridge, and they look brand new. You can't tell the difference. So the whole point of this is please read your manuals. And there is detailed instructions how to go through the cleaning steps of your cartridge. And remember that after 50 uses, approximately, you're going to need to replace these, right? You can order those from NuSmile. And if you look at the photo there in the lower right, I start changing my cartridges when you start seeing these longer cracks. You're going to have some cracking. It's plastic. It's going to happen. But what we want to avoid is holding onto this cartridge for so long that and not changing them out where the plastic actually cracks. That's possible because these are not meant to be used more than approximately 50 times. So just follow the directions. Go into your IFUs, read this, have your staff read this, and just follow the directions as far as sterilization. And remember, you get about 50 uses per container, and then you need to buy new ones. Okay, the cost isn't very great, and I would consider just printing out the instructions for sterilization and giving those to your staff. This is an important one. I've had a few patients that started complaining of pain when the patients were checking out. So maybe they were in the office for less than an hour. Why is that happening? And we talked about this as a group earlier this week. And my theory is that we need to remember, and if we look down here in the lower right, we need to remember that the working time of an intraosseous injection is going to be shorter than a block. That's just what happens. And I appreciate that. It lasts less time. So if we're using 1 to 200,000 epinephrine concentration with our Septicane, you're going to get 30 to 45 minutes. Okay, 1 to 100,000, right? Blood vessels are clamped down. It's going to stay longer. You've got 45 to 60 minutes. So if your patients are in the office for more than an hour, they may start having some symptoms. But guess what? If you gave a block, your patients were still having pain when it wore off. They just happened to be at school or at home and you didn't hear about it, right? So your patients are not experiencing more pain. It's just the local's wearing off faster. So how do we, what do we do to manage that? Is we may want to think about if you need longer working time, you may want to use 1 to 100,000. Now, we'll talk about in a minute here of why I use 1 to 200,000 most of the time. But again, you have a shorter working time with IO delivery. This is a proposed extraction protocol for minimizing postoperative pain. Some doctors have gone to this if they're really worried about things, is they're giving, and this isn't just for IO, you can use this for, any procedure where you're giving local anesthetic, but think about pre-medicating with an OTC pain medication, Motrin or Tylenol. If you're really worried about maximizing the length of your effective local anesthesia, we may want to use 1 to 100,000. We know that once you give that IO injection, that patient is immediately profoundly numb. If you go do 6 checks and you leave them in the chair, that local is going to wear off faster. And then worst comes to worst, if you're really worried about, if you have extractions, it's a difficult extraction, you're having to really do a lot of manipulation of roots or remove bone or put in sutures, you may want to think about at the end of the procedure giving an additional IO or maybe giving some infiltration. I wouldn't necessarily, you could give a block, but then you're going to have to deal with the collateral numbness, but you may want to back up and give a second intraosseous injection at the end of the procedure. Again, be careful with your total amounts of local anesthetic based on the weight of the patient. Storing your device. I didn't realize this until I posted or sent Dr. Print a photo. Your SOAN should not stay on the charging base if it has a carpula of local anesthetic in it. And the reason for that, now it can stay on the base if you don't have this preloaded, if it's just charging, of course. But the reason for that is if, and this is very rare, if for some reason that compula of local anesthetic broke, it could drain down into the unit and harm the electronics. I don't think that is that doesn't happen very often. I've never heard of it happening, but it's a possibility. Same thing with your Sleeper One. I happen to have mine mounted on my ADEC unit here, and it's okay at rest when it does not have a cartridge loaded to have it in the upward position, but don't do this. Have that, it's designed where it can be flipped down or on an angle once you have that cartridge loaded. All right. Going back a little bit to the basics, please know for those of you that are new to these devices, the idea of giving an anesthetic via the intraosseous route is not new. This was back in the 1900s. And what this French doctor discussed here is that once you inject into the cancellous bone, that analgesia, that anesthesia, is immediate and absolute for everything that it touches. So that means your tooth, the apex, your soft tissue, everything where the cancellous bone is attached to will immediately and profoundly be numb. Okay, this was the 1900s. The US, as with some things, are late to the game with some technologies. And I'll tell you that you can see all the countries that have had these devices far before we did in the United States. So this isn't something that's just, new on the market in the world. These are used all, North America and Canada, in Asia. There's a large diffusion of dentists using these all over the world. And that is reflected in our instructors, our KOLs here in the US. And we have this large group of international, very talented doctors that teach these units, educate all throughout the world. So remember, there are two different units. For those of you new, there's the SOAN and the Sleeper One. The SOAN is portable, right? And the Sleeper One is corded. And it's really up to you. There's pros and cons for both. If you're only going to buy one, and I encourage you, if you have multiple operatories, do not move these back and forth. You're going to want several units. But if you're only going to buy one, you're going to buy a SOAN. Most people, I think the sales are much heavier for the SOAN versus Sleeper One. But I'll tell you, I own both, and I prefer the weight and how I hold the Sleeper One versus a SOAN. But the business end, they're going to do the exact same thing. The overall features are going to be similar. The way that you're going to give your IO is going to be the same for them both. Cost-wise, there's a little bit of investment in this, but I will tell you that these units have more than paid for themselves since I've acquired them. Okay, and it's just the Sleeper One is a little less expensive. It's corded, and there is a bulk discount if you buy more of them. I don't know. It only says 3, maybe. If you buy 10 of them, maybe NuSmile at one time they'll give you a break than that. I don't know. Okay. The SOAN is, again, it's portable. It comes on that charging base, doesn't come with a koala, but the needles that we're going to use for both units are exactly the same, okay? And you need to remember, if you are transporting the SOAN from one operatory to another, sometimes your staff who's new, they may just bring the SOAN and forget the foot pedal. You need the foot pedal, okay? In the IFUs, in the instructions, there are some features and some settings that we can change, all right? The wireless pedal, I want you to remember that, and this has come up before, if you are putting your foot on the pedal and pressing both buttons accidentally, the top button is always going to win. The drip by drip for that stage one is always going to win. So if you find, and this happened to me at the very beginning, if you find your delivery is taking a very long time, you may still be on that small button, okay? On the upper right of the pedal, that's where you'll change your speed. Now, if you're giving this, if you're using intraosseous delivery, you're always going to be on B for baby or B for bone. The only time you're going to switch there to the pink is if you're giving an infiltration or a block. And on the upper left there, you have your aspiration. You remember you can, I don't think I've ever given a block with the SOAN. You can. After you give about 1/8 of a carpule, if you have it in that high mode in the pink, it will give you aspiration. Okay. And as far as settings go, you can, if you want, you can change power. Now, cruise and drive, that's really up to you. There are 2 modes. Cruise is going to allow you to define, number one, how much local you're going to give. So either a carp or quarter, a full, 3/4, half, or quarter. And you're going to just click it once. It'll give you your desired amount, and then you click it again to stop. And that is going to come into cruise mode. I personally, and I think most doctors, have their units in drive. I want to just be able to hold down the large pedal, and I will let go after I've given my desired amount of local anesthetic. But just remember, if your foot is touching both buttons, that drop by drop is going to win. All right? The Sleeper One, the pedal is very similar. Okay, it does have 3 different colors. One blue for bone. It's always going to be there, and then they're separate for the giving it an interligament or a palatal, or giving it a block in orange. But most of the time, you're just going to keep this on blue. Remember, you can, for your Sleeper One, I think it's nice to just run your power cord through your delivery unit. That's how I have mine. And it does come with a holder, and you can mount it. This comes with all of your units. So why is it important that we do give, we use an electronic device? Okay. The reason for this is, and I will tell you, I saw a post a while ago where someone said, well, I'm just going to put a Effitech needle on the end of a manual syringe. You could do that, but I will tell you, number one, you're not going to give a pain-free injection. And number two, you're going to have almost no control over the spread of your local anesthetic. If you, with a manual syringe, there is no way possible to give as slow and directed delivery of your local as you're going to get with an electronic device. We need to be able to give our anesthetic drop by drop. Your SOAN specifically is constantly monitoring pressure. It's not going to let you get in trouble. It's going to give your patient the appropriate amount of delivery force pressure of that local anesthetic. And if you're giving that anesthetic at the appropriate speed and pressure, you're not going to be worried about perfusing too large of an area. We need to keep this local within that area of that we want to have profound numbness. Many of you have seen this diagram in the intro and during your onboarding. There's one thing I want to point out here. We talked about that in general, that the upper arch does not have a bias of flow, meaning that it's omnidirectional. When you inject intraosseously and you come through the cortical plate, you're going to have perfusion to the mesial and the distal, both in equal amounts. And typically we say that you're going to get 2 teeth mesial and 2 teeth distal. Okay. Now, the thing we need to remember is this is not always the case with our primary dentition. With that 9mm needle, you will likely be able to get at least 1 tooth on the lower, 1 tooth to get this area numb, 1 tooth distal and 2 teeth mesial. On the upper arch, at least 2 mesial, 1 to 2 mesial and 1 to 2 distally. But just remember, if this is a teenager with the 9mm needles that we use, don't expect to get this much of perfusion. You're likely only going to have profound anesthesia with 2 teeth. And the reason the difference is when we use the 9mm in a child, we're really giving osteocentral delivery. But with a teenager with a 9mm needle, this is really more interceptally. And so you can't guarantee you're going to have this diffusion of flow. One of the points and one of the major significant changes with these devices is we don't have to worry about midlines anymore. Completely take that out of your memory banks. We can give on the same day, we can give an injection on the right and the left, and we're not going to have to worry about getting crossing midlines with intraalveolar injection. Okay? This just doesn't happen anymore. All of you should be familiar with these needles, but the amazing technology that's gone behind this needle is it's a different shape. And I will tell you, it's if you come at that about that 15-degree angulation and you just give a little bit of pressure, the needle is designed almost like a scalpel, and it will pass through that soft tissue just superior to the cortical plate. And if you do this correctly in the right angulation, your patient should not feel the initial injection. Majority of the time, now our units came with 2 different needles, but I will tell you 99.9% of the time, I'm just using the green. Okay, in our pediatric population, we're just using the green. I will tell you that I am 99% successful with an intraosseous injection with all patients under 14 years of age. As you get older, remember the bone can be thicker. And so there was one post recently where someone had an issue with a 20-year-old. That 9mm needle and these devices are not designed for teenagers. Will they work in young adults or even adults? Yes, they will, but it's not necessarily designed for that. That 9mm needle really is for our primary and our mixed dentition. For those of you that have struggled with bending needles, I know I did it first. I had a tough time when I was so worried about angulation, and then the needle would bend. I haven't bent a needle for a long time, and I'll tell you, it comes from 2 different things. Number one, you need to grip your SOAN or your Sleeper 1 as close as you can to the junction between the needle and the cartridge. So you're going to hold this like a pen. That's the first step. If you hold too close to the base of the unit, what will happen is this becomes a lever. And as you give pressure, you're going to tilt your hand. It's going to happen. So first and foremost, pen grip as close as I can to that junction. Then number 2, it's finger position. In the video at the very beginning that Dr. Bond shot for us, it's a beautiful example, but if you notice, he didn't have his finger resting on the teeth. He did that because it would have been in the way of the video. But when you give these injections, I want you to make sure that you have a finger actually resting on the teeth. The reason for that is as you pass through the cortical plate, you need to have directed force actually parallel to the needle. If you don't have proper finger position, you can see here, doctor does a good job. They have nice stable base. You're more likely to, as you exert pressure, to bend and to move. And if you do that, you're going to bend a needle. If you learn, again, to hold close to the hub and perpendicular or parallel forces down the long axis of your unit, the chances of bending a needle for a patient under 14 years of age, even sometimes older, are very, very low. Okay? If you find that you are having pain on that, on just the very first step, when we're numbing that papillary triangle, you may be coming in too steep of an angle. Okay? So the whole point of this needle and having the D facing out is we want to inject with that flat side as close as we can to the periosteum without actually touching it. And that's why that initial angulation is so key. We're coming in about 15 degrees. And again, remember, please don't push. You just need to give a little bit of almost a bend or just slight pressure down as you slightly advance. The needle is so sharp, it'll pass through. And if you're coming at the right angulation, about 15% off the soft tissue or off the teeth, then your chances of actually touching the periosteum are almost none. Okay? And again, you got to watch your depth there and not touch the periosteum. Let's talk quickly about anesthetic choice. The reason why that we choose to use articaine in our population is that we know that it's soluble in the blood instead of the liver, and that it breaks down in the actual plasma. Okay, the septicaine just breaks down faster, and the perfusion is better because of that thiophylline ring. We know it's lipid soluble, so vast majority of the time we're just using articaine here. So again, articaine in the U.S. at least comes in two different concentrations. Okay, it's both 4%, but it's the epinephrine, either 1 to 200,000 or 1 to 100,000. What I do in my own practice is everybody gets 1 to 200,000 unless I'm doing an extraction where I'm really worried about having profound anesthetic just in one tooth or two teeth. And I'm not worried about length of the anesthetic. So for the run-of-the-mill, if I have an extraction, and especially if it's a hot tooth, I'm going to use the 1 to 100,000. But vast majority of the time, I'm using 1 to 200,000. And my staff knows if it's an extraction, if that area is very irritated, or I know it's going to be a longer procedure. Let's say I'm working on a very difficult hypoplastic adult first molar on a 6. I may use the 1 to 100,000, but vast majority of the time, it's the 1 to 200,000. Especially for your teenagers, I would really suggest using the 1 to 200,000. The reason for that is we talked about this earlier, that you're really giving just intraseptal delivery. You're not giving osteocentral. And if you deliver too high of a volume into that interseptal bone of 1 to 100,000, there's a higher chance of having some tissue ischemia just because lack of blood flow in that area. So, and we have these labeled in my practice in the drawer. The colors are different on the actual carpules of anesthetic, and 90% of what I use is going to be that 1 to 200,000. I would suggest having both. Okay. The idea of using that 1 to 200,000, I know it's a very small difference in the amount of epinephrine, but I do find it does make a difference, especially in the working time. Okay. I want to just briefly talk about how much local anesthetic that we give. If you remember from the very beginning in the manuals, there are 2 different manuals that are available online for each unit. One is the clinical guide, and the other is the IFU's instructions for use. I really encourage you, and I'll show you some slides here, to go through that clinical guide, because it does tell you in detail for the different types of injections in different areas of how much local to give. But let me just give you my general guidelines. If I have my average 7-year-old patient and I'm giving, and I'm going to, treat S&T, I'm going to give a quarter to a half carpule of local anesthetic. If I have multiple teeth in a quadrant and I need to numb as many teeth as possible, I may go up, usually not a full cart, but I may go up to 3/4. Okay. You will be using generally less local anesthetic than you would if you were just giving an infiltration. Let's talk about the most basic intraosseous injection, the one that I recommend starting with. Okay, so this is your quote unquote your pediatric IO. You're now just going to take over from your block. You're going to go ahead and anesthetize and enter between S and T. And in this case, I'm giving a quarter to a half carpule of local anesthetic. When I do that at 1 to 200,000, I know I'm going to have profound anesthesia, 1 tooth distal and 2 teeth mesial. That I can guarantee you, right? When you start for your first injections, if you're right-handed, I would suggest starting with S&T. I think it's going to make it easier just for you to see positioning-wise, okay? Remember that we're going to start that first stage slightly lateral to the midline, and we're going to just put some pressure. We're not going to go straight in and start at the middle of that papillary triangle. We just want to be 1 to 2 millimeters lateral. In that first stage, and all of you that have these units have already seen this, the reason why we use the small foot pedal is because this is just giving drop by drop and it's not speeding up. Some of you have asked, well, why can't we use the larger pedal for the whole procedure? The reason being is because the small pedal is giving slower and it is not it's not ramping up your speed as you continue to deliver. This is drop by drop local anesthesia. So that's our very first step. You see how the doctor's doing a great job with their not only holding close to the hub, they have great finger position. How much local do you want to give here? It depends. Just enough so you see blanching only in about that 4 millimeter papillary triangle. If you see that you're starting at blanching down into the vestibule, you've given way too much at that stage and you have a higher chance of that collateral numbness. So you've got profound amount of you have profound local anesthesia here just in that area of the papillary triangle, and you've got profound anesthesia in your periosteum. Then our bone penetration. What I want to remind everyone is you're not going to necessarily feel the pop every single time. All right. I find that patients sometimes 6 or 7 and above, you're going to have a much higher chance of feeling the pop, but for that 2, 3, 4, 5-year-old, sometimes 6-year-old, it doesn't mean you've done things wrong. It just means that their cortical plate is thin enough that you're passing through without feeling a pop. All right. And on the lower, again, for this patient, let's say they're 5, you may not feel the pop in this area. You may not. But at least you know that you're going to be delivering enough local anesthetic to have profound numbness, 1 tooth distal and 2 teeth mesial. Now, if I had no other uses for these devices except for this, I would be happy. Please remember that the midlines don't matter anymore. And with that 9 millimeter needle and giving a sufficient quantity of local anesthetic, if you want cuspid to cuspid, I typically am giving 3/4 of a carp here, you will have profound numbness definitely in those 4 incisors and likely into your canines. And I will tell you that patients do not react in these areas. It is amazing, and you're giving 1 injection, just 1. And this is the case that completely sold me on this, was that I could give 1 injection and have profound anesthesia on 4 lower anterior teeth. Okay. I want to make the point of looking at the angulation here. You see we're at about 45 degrees. We're a little superior to the crest. As we're giving pressure here, do you notice that she's not changing her finger position? If you start bending, then you're likely going to bend the needle. The other thing that we can do is if you're having a problem passing through the plate, you can do a little bit of rotation. That little bit of rotation, counterclockwise, clockwise, may allow you to advance that needle. And just remember, you may not always feel that penetration. And these are not set in stone, this is just my feedback, is that under 10, you're going to feel kind of resistance. You won't always feel a pop. 10 and above, you're always going to feel a pop. I find 7, 8, it just really depends on the size of the patient, how thick that bone is. What I also want to remind everyone is the more apical that you move your needle, the thicker the plate is. So if you're not starting, just the base of that papillary triangle and not at the right angulation, you're going to have a thicker area of cortical plate, right? And you're going to have a tougher time passing that needle through. Please remember that you need to change your needles. If you are struggling, you feel like your angulation is correct, you're in the right location, but you can't pass through, you feel like everything's going right, I just can't pass my needle through, you may need to change your needle. The other important concept is if you've given an injection in one quadrant, I will change the needle every single time. If you notice, because these are so sharp, once you penetrate the cortical plate once, you're going to have that needle deform at the end. That's just how needles work. Please make sure that if you plan on doing 2 quadrants during that appointment, that you have your staff have 2 needles out so they don't have to go inside the drawer. All right. And you see you're not entering very deep. So you're not worried about hitting any, an apex of a tooth or the side of a tooth of a root. All right. Please remember that inside that cortical plate, they're not nerve fibers, but they're still those C fibers, and they may feel pressure. So if your patient makes a noise, if you see them move a little bit, they're likely not feeling pain, they're feeling pressure. And sometimes I have to remind parents of that because, they may say, oh, is it hurting them? No, it's a little bit of pressure. They're just feeling, the pressure of that local anesthetic. Now, these slides come from the X-tip when we were manually drilling, we were using basically drill on our slow speed. But what I want you to see, the important thing here is looking at the thickness of that cortical plate. Okay, so we want to be just past, right at the base of that papillary triangle. And as we enter the bone, we want to be perpendicular to that surface. So please don't forget, next time you take out a posterior tooth or an anterior tooth, look and feel around that area of the cortical plate to really get an idea of what does the cortical plate look like in your patients. All right. Blanching. A confidence marker, the way that you have profound local anesthetic delivery in both the buccal and the lingual or the palatal is blanching. Now, I'll tell you that I don't always see blanching on the palate, and I typically don't have a problem with having to give a second delivery. But if you really want to make sure that you have profound numbness in an area, you're going to look for blanching on the palatal or lingual. Now, if you have blanching on both sides of the gingiva immediately, please know that you probably were not giving an intraosseous anesthetic. You were likely just passing through the papilla. So you're going to see that blanching, but it's going to be a little delayed, right? And again, power, plan, pedal, and position. Think about taking a photo of this and just going through. I literally do this mantra every single time before an injection. I'd like to remind everybody about rotating. Sometimes the bone is thick in those areas. And if you notice here, the doctor is doing just slight rotations, Dr. Alp, and he's able to pass through the bone, but he's having to give some rotation. I want to skip ahead and talk about bone level. Okay. We do not want to give an injection without having a radiograph. And the reason why is, number one, I need to make sure that I'm passing my needle in an area when there's no other tooth structure or other anatomy. There's not a supernumerary tooth, and then that I have an adequate level of bone. In the lower anterior, this is the case that told me that I wasn't going to do any other technique. Okay, I gave that first stage. Patient didn't feel a thing. And then I backed this up. The orthodontist want 4 lower anterior teeth removed. I gave 1 intraosseous anesthetic, 1 to 100,000 Septicane with 1 to 100,000 epinephrine, half a carp. I immediately took out the needle and extracted all 4 front teeth. I used to do this with 3 to 4 different injections, and I just don't have to do that anymore. Okay. Volume-wise, and you may want to write this down if you're new, you are going to use anywhere from that pediatric patient. If you're going to numb that lower right quadrant, you're going to be 1/4 to 1/2 of a carpule. If I'm just doing occlusal composites or small interproximals, I may only give, for a younger patient, I may only give a half a carb, okay? Um, or excuse me, a quarter of a carb. If I'm doing pulps, I may go up to a half a carb. Very rarely do I ever need to give more than that, right? And just remember, for your teenagers, the older patients, you may only get one tooth mesial, one tooth distal because of that 9 millimeter needle, right? Please, please, please look at your radiographs. Okay. And in this case, although we have, a pulpily involved tooth, there's not an infection. So we still have good bone there. If you have bone loss in that area, or you have a periapial radiolucency, that site may not be adequate, may not be appropriate to inject into. All right. The other thing I want you to remember is you don't always have to go from the buccal. If I have a patient that I need to, and I'm right-handed, if I need to give local anesthesia for the upper left-hand side for I and J, I may give this palatally. You can absolutely do the same exact steps with a palatal injection. Now, most of us are not used to giving palatal. I tell you, the first time I gave a palatal injection in many years was only with a Sleeper 1 or SOAN. Remember, on the palate, you only have 2 roots to deal with on 2 teeth. You don't have 4 there. So you actually have more room. And if you need to, give it palatally. There's no difference. We definitely want to review our radiographs and see where we have an adequate level of bone. Now, there's no infection here. Anatomy is quote unquote normal. You don't have issues with root proximity. And you can give, if I'm going to numb that lower right-hand quadrant and I want to numb the permanent first molar and S and T there, I'm going to give distally to tooth number T. You could also give mesially to tooth T if you're just planning on numbing R, S, and T. All right. Angulation matters. I love this video. It's available on the NuSmile recorded webinars as well. But remember that you want to have your finger position slightly different here. I want to talk about infected areas, right? So you can see there's significant amount of bone loss here with this infection. This is not an area, typically, let's say I was just doing composites or a pulp on K and L, I would inject on interproximal between K and L there. But in this instance, I know I've got bone loss. I know that I will probably have issues if I try to inject into that bone that's not organized. In this case, I would think about giving half my injection distal to K and the other half of my injection mesial to L. Again, you've got to look where you have adequate levels of bone and you don't have an infection, right? S and T, that's the same thing on the other side. No infection there. Actually, that's different. Should have plenty of bone. S may be infected there. So I would think about, again, supplemental, giving it in 2 different sites. I would just split my local anesthetic up. So both distal of K and mesial of L. And if you need to, you may give it palatally. We have issues like this with root proximity, right? If we're going to numb the that second and first molar, I may have issues getting that injection between those 2 teeth. So I may just have to make sure that I'm giving my intraseptal anesthetic delivery on the mesial of that first molar. We've got to look at our radiographs. If you don't have a tooth, if you just had an extraction recently, let's say if tooth number L, there's not bone there, that's not a good site. So we're going to need to go 1 tooth distal. The whole point of all this is we don't have to make it too difficult to understand. It's look at your radiographs, look for bone. Canines sometimes are an area, especially if they have ectopic permanent cuspids, you may have issues with root proximity or location of that permanent cuspid in the area you want to give your local. So you may need to choose either mesial of tooth number C there or distal of tooth number C, but look for bone. If you find that you've got issues with root proximity, you can also give it palatally. It's a little harder to see, of course, in the anterior, but most of the time, if I'm extracting primary canines, I'm going distal to those primary canines. Canines sometimes can be a little tricky for the fact that we know in those canine eminences, the bone is a little thicker, so please be patient. Canines, I find, are some of the most difficult. Maxillary primary canines can be the most difficult area to anesthetize for some people because of that canine impedance, because the bone's a little thicker. You can get intraosseous injection in those areas. You may just need to work for it a little bit more. And again, let's look at our radiographs. If you don't have odontoma there, that may be your way of getting adequate local anesthesia. We're going to check our bite wings every single time for caries and also for placement of our local anesthetic. Now here, there's no infection. You've got good organized bone. You're just going to make your choice of your injection site based on how many teeth you need to numb. Again, on that lower, 1 tooth distal, 2 teeth mesial. On the upper, it may be 2 and 2. And if you're treating many teeth in that quadrant, canine all the way to permanent first molar, you may find that you need to give 2 intraosseous injections. You may not get profound anesthesia going all the way to that canine if you also need profound anesthesia on your adult first molar there. Okay. What do we do with the sinus tract or a parulus here? This may be an area where I need to give my IO in 2 sites. And I will often do, if you have a pulp polyp or you have areas of infection or unorganized bone, I may give half that carpule on the mesial and half that carpule of the distal if I'm giving a full carp, or half and half. You can get profound anesthesia with in an area that's infected. You may just have to choose which site that you can get into sound bone. Palatal, again, it's a great way to access, especially if you are right-handed. Remember that you only have 2 teeth, 2 roots in your way on A and B or I and J. So it is a great site. And if with practice and giving this a couple times, you will find that your worry about giving palatal anesthesia will go away. It's a great way to access. You can see, and I encourage you, if you haven't done that, to try it. One of the most amazing, besides not having collateral numbness and for anteriors being able to numb multiple teeth, hypoplastic teeth, we know that getting profound anesthesia with a block sometimes is very difficult. And I can't tell you if I've ever had an issue with having adequate local anesthetic and numbness I treat a lot of MIH patients, and I will tell you without a shadow of a doubt, I think I'm probably 99% of hypoplastic teeth that I've been able to get profound local anesthetic for. And we know trying to do this as a block with a hypoplastic tooth, the numbers are very poor. But in this study, 88%, 88.9%. I'll take that any day of the week. And I find, again, my success rate is even higher than that. All right. If you have a sinus tract, if you have an active infection in an area, there's already pressure built up there, correct? You also have acidic condition. So if, let's say I have a sinus tract between the primary first and second molar, not a good area to start injecting into a space that already is pressurized. So in this case, I'm going to give mesial to that, the primary first molar, and I may need to give also distal to the primary second molar. But if that tract here is between both teeth, I don't want to give my IO in that area. Okay. Just a couple questions from Facebook. Why is my local still coming out of syringe when I'm not pressing the pedal? If you're not familiar with cruise and drive, there's a great video. Aaron just posted that. Please go to the Facebook group and you'll see. And just remember that top pedal is always going to win. So if your foot is not in the correct position, you may think you're stepping on both and you may only be on the top pedal there. Okay. A couple of you have asked about, is there a battery inside the foot unit? And there is not. Okay. It creates its own power, but without going into detail. And it sends a radio wave to your unit. So you don't have to worry about replacing batteries. Okay. Pop in the bone. We went over that. Under 10, don't expect it. If you have it, you have it. But I would say patients 10 and above, I will feel it pretty much every single time, except for on erupting second molars often. Even for older patients, that bone, the plate is not very thick there. So even for older patients older than 10, you may not feel a pop with erupting second molars. Okay. We talked about you may need to have 2 different sites if you have an abscess or give it palatally. Absolutely fine. And if I was pressing the pedal but the light was not blinking on the unit, it may not be on. So please remember that mantra ahead of time. Okay. I finished a carpio on the unit reset when I was still in bone. It's aspirating. Is that bad? No. Just remember you are passing through an area with a lot of blood vessels and bone, and you may have a little bit of blood that's inside that aspirated carpio, totally normal. And post-op anesthesia or post-operative pain, just remember it shouldn't be that much different than what you're doing now if you're not using these units, and you may want to think about giving OTC pain medication before the appointment. Okay, I think we talked about lights, and we were right on time at 6:30, and I want to turn this over to Chris.
Awesome. Thank you. Perfect timing. Appreciate that. We are going to open up question and answer period now. So just a reminder, everybody, the chat feature isn't working. So if you have questions, just use that Q&A button at the bottom. We do have a few, so we'll jump right into it. First one is, I was on the Zoom webinar 2 weeks ago. At the end, someone asked about ischemia of the bone. The speaker said, yes, it can happen, but that is all she said. So my question is, how quickly would we notice osteonecrosis with the psoas? How does it appear, signs and symptoms, and what is the treatment in children? Thank you.
Yeah. So I wasn't on that webinar, but I believe probably what they're talking about is soft tissue necrosis, right? So if because there's so much blood supply in the bone there that I'm not in the volumes that we give, I'm personally not aware of an issue with issues with perfusion of blood in the bone. I think what they were probably referring to is if you are using Septicane 1 to 100,000 and you give a large volume just interceptally, that can be an issue where you have some tissue necrosis. So again, if you're using that higher epinephrine concentration, we need to watch our volume and we need to watch the site that we're giving. For teens, I'm only using 1 to 200,000. That's all. And I'm watching the volume I give. I find I don't need more than a half a carpio because I'm not expecting to get multiple teeth, 2-3 teeth three or more teeth in that quadrant. You're really 9mm needle, you're going to get 2 teeth. I mean, you may get 3, but I think it's just a matter of watching that concentration of epinephrine that's there.
Thank you.
And if you have, and that may be a question you want to post into in the Facebook group to get more clarification. So whomever that is, if you have access, if not, sign up for the Facebook group. Here's a shameless plug, and please post that question tonight. And I'm sure you'll have an answer by tomorrow.
They are in the Facebook group as of about 30 minutes ago. So.
Okay, perfect.
We did have a lot of people join during this, so thank you for that. Next question is, I started giving infiltrations with the psoas after IO and extraction, and the extraction is completed because it wears off so quickly, and the patients were having pain once they got in the car. Any thoughts?
Yeah, I don't think there's a problem with that. I would just watch your volume, because we know with higher volumes, you may have an issue with collateral numbness. But here's the thing, is that these patients, they were always having the pain afterwards is not associated with the actual IO. It's just their locals wearing off, right? And so I know for a fact that a lot of these patients, they were having pain. They were just having pain when they were not with their parents, either in the car or in their office. It's likely they're back at school, or they may be at home running around with siblings. So you just, like after any procedure, you need to talk about pain management, right? If you know that it's going to be a painful procedure, you may want to preload. I mean, there are some doctors, for almost everybody, they tell parents to give Motrin or Tylenol ahead of time. I don't think there's a problem with that, but let's just think about what procedure we're doing if things are going to hurt, and you may want to give Motrin or Tylenol. I think it's absolutely okay to give supplementary infiltration, but just, again, watch how much local that you're giving, because the higher volume, you're going to get numb lips, and that's definitely the antithesis of what we want.
Next question is, I had a fail this week. I know I was in the correct location, gave half a carpule of 1 to 200 articaine in the mesial papilla of 13, but the patient was not fully numb. I gave the remaining half a carpule in the distal papilla, and he still had pain. Ended up infiltrating and looking at his pan. He had super long roots. Is that the reason IO did not work for
You
me?
got it. Yeah, it's so the thing we need to remember is that 9 millimeter needle is you can have complete confidence with a primary dentition or mixed dentition. The older the patient gets, to get true, profound anesthetic and a permanent teeth, especially multiple permanent teeth in that quadrant, you really need to give osteocentral local. Okay, if you're going to get multiple teeth or expect to get even palatal, profound palatal anesthesia. And what that means is you'd have to go up to a 16 millimeter needle. The reason why we don't use those is because you're going to bend. It's very difficult to use that long needle to manually penetrate through the bone. And so what your patient was experiencing is you just had to make sure that had to know you're giving it intraceptally, and that you may need to give a little higher volume like you did in two different sites. I don't have that experience where I feel like I don't think I've ever given a full carp. What also may have occurred is that you were very high up on the septal bone and you didn't really perfuse a lot of that, was mostly in that interseptal bone in the soft tissue, and there just may have not been enough perfusion down into the true cancellous bone near the apex, and that may be an angulation issue. If that happens again, for all of you, ask the parents' permission, have them sign a consent, videotape. I keep on saying videotape. Take your iPhone out and take a video and send it to us, because then we can truly diagnose, is it your angulation? What's the problem with why you're having a failure?
Along those lines, do you use the 16 millimeter needle for teens or 9 millimeter for all ages?
A 9 millimeter for all ages. I mean, for the infiltration, I guess you use the 16 millimeter needle for that, right? Or for a block, but I find I just don't need it. I still have the box up on the shelf. I'm using a 9 millimeter needle for everything. But technically, yes, for an infiltration, you can use the 16 millimeter needle. I just find I don't need it.
Next question.
Before intraosseous anesthesia, I was using a short for maxillary teeth. I was using a short for everything. If I'm giving, even for actually mandibular, I'm using a short needle, that 9 millimeter needle for everything if I'm giving just an infiltration.
Next question is a good one. You definitely have the experience to answer this because you've used a lot of other similar wannabe type of devices. So question is, I'm a complete newbie. I was at Chicago Midwinter meeting last week and stopped by a booth that sells a device that looks similar to the wand. He
Correct.
stated that their device is far superior to this device. Could you please touch on this briefly?
Okay. As far as I know, the SOAN Sleeper 1 is the only device that is FDA cleared for intraosseous delivery of local anesthesia. Did I say that correctly, Chris?
Electronic assisted delivery of intraosseous anesthesia.
Assisted delivery. So the issue is that if you go buy another unit, or you buy it from eBay or a different company, and I'm not telling you this so you just buy from NuSmile, is that these devices are specific for intraosseous injections. The algorithms are specific for intraosseous injections. And if you use a different device for an intraosseous injection and you have an issue, that's on you, because if you look at the instructions for all those other devices, they don't tell you they're for intraosseous delivery of local anesthetic.
Next question. Hypoplastic permanent molar.
Oh, I love it.
Septicane with 1 to 100 versus 1 to 200,000 epi, and site of injection for IO.
Yeah. So I find, the thing is you're likely going to treat those teeth as soon as they come in, right? And so not always, but pretty early on. So I find vast majority of the time, I'm just going to give it in the mesial of that permanent first molar. and I stick with 1 to 200,000. You could go 1 to 100,000 if you're worried about length of procedure. If you have a big buildup and you are not comfortable treating those, that's one of the procedures that I teach. So my speed is pretty decent on those, and so I get them done pretty quickly. But if you're worried about length of time, it's okay to give 1 to 100,000. But I find I don't need it. And really, in my practice, I keep it simple. If it's an infected tooth, then I'm giving 1 to 100,000. If not, I'm mostly using 1 to 200,000.
All right. Next question is extraction of CNH.
Yeah.
Is it acceptable to give one injection at the papilla of 8 and 9? I have tested it on a few patients and have had good results, but want to make sure profound anesthesia is expected. If
it's working in your hands, great. I've done both, and I think it's absolutely fine. I tend to do 2 injections more frequently, but if it's working in your hands, yes. The patient's not feeling it means you got profound local anesthetic delivery for your patient. So it's absolutely fine. If it's working in your hands, do it. You can give either way. Basically, you just need to get past the cortical plate into the cancellous bone, and that could be between 8 and 9, or that could be 2 different injections on the distals of CNH. So I don't think there's a right answer there.